All righty, welcome everybody. It is December 8th. We are in the final stretch of the year here in 2023. And I've been asking Dr. Pepe to come on and speak about this topic because everywhere we go around the country, we keep hearing people saying these things that clearly demonstrate a lack of knowledge of the physiology. Um, Actually, today, what I just posted on Twitter was something that I said, have you fallen into any of these traps? Used a small BVM in adult cardiac arrest. Increased the ventilation rate to 20 to 30 in peds. Hyperventilation equals overventilation. GCS less than 8 equals intubate. I think many people around this country have fallen into those traps. And I wanted to ask Dr. Pepe to come on today and really give us a nice framework, which how to think about respiratory support during CPR, during severe hemorrhage, so that we can start to educate our EMS professionals in the field to do the right thing. So without any further ado, Dr. Pepe, thank you for agreeing to do this. Take it away, my friend.
Okay, good. Thanks, everybody. So I really appreciate, and this is what I'm about to show you is not perfect or exact, but it's probably the best approach to things. And I've been doing this for years. And a lot of times people we were in the 70s in Seattle, they thought we were fudging our data. But I think what was happening, we were doing really good CPR and really paying attention to it. And we were ventilating people appropriately, as everybody would say, ventilation. You'll see in a second, I'll be talking about it in terms of respiratory support. So, and you'll see why as we get through this. Okay. All right. So, with that, thanks a lot. I thought first of all, disclosures, right? The only thing is I'm not a morning person. I had a late night here last night. I'm in Las Vegas, assisting one of the tours here, and we got out late. And so this is like a few hours after I went to bed. So I hope I can be clear. There is a lot of heavy physiology in a sense, and I'm going to try to make it unheavy. But I want to also, we may go into a part two, Peter, if I don't get through enough. I'll try to keep track of the time better. Okay. So before I get started, I just wanted to say that most people probably know my background from my Seattle days there, working with the beginnings of the Medic One system and doing training out in the field, including respiratory stuff here. And the thing, what most people may not know is I started off really as an ICU doctor. So I was a critical care specialist. And then I did because of my fellowships were very heavily, I don't know, academic or what you want to say, research oriented. I did a lot of research in the laboratory and in the streets as well. And so as a couple of examples of that, would have been everything like I actually used, mass spectrometers to measure oxygen consumption and CO2 production and in inflection points about how, as you lower oxygen delivery, what happens, so there was just a lot of heavy duty stuff in the laboratory. Then there were some clinical things like the concept of how I came across the thing of we call auto PEEP today, and et cetera. And then later that kind of helped me lead to helping out with the Heart Association and various other people about at least appreciating that that you probably can get away if people are gasping, you can probably get away with just doing compressions only, et cetera. And some of the things you're all aware of under these periods. One of the things you may not be aware of is that for years I was treating people with hemorrhagic states. I don't say shock because I don't know how you define shock, but people who are in hemorrhagic states, how just mild positive pressure ventilation with mild, even moderate hemorrhage can be really detrimental. And so we're going to talk about that a little bit today. If not, we're going to come back to this because I think it's worth. I think it's really worth repeating this a little bit. One of the reasons I put this picture up is that I'm still working in the laboratory, and one of the things we're looking at, for example, still is the effects of, for example, what tidal volume you choose, for example, on blood flow through the lungs, and we'll be getting into this in some detail. So I just want to know there's a basis for this beyond just being an EMS folks. But that's my job actually, was to take this stuff we learned in the laboratory into the streets and sort of practice that not only in Seattle, but then later here in Houston, as you can see. All right. And that brings us to today's requested topic, the physiological approach to respiratory support on the streets. Okay. So I like this, like most veterinary students, Doreen breezes through chapter 9, which is, equine medicine, taking care of horses, broken leg, affected, shoot. So we're going to kind of breeze through here. And I apologize because if you don't get it all, I'll come back and talk to you or talk to individuals about this as needed. All right. So for the last, 20 years, there's been a focus on quality CPR. We've had the Resuscitation Academy and all that. But what's been strange to me is that there's not been a focus on quality ventilation, because these two are totally integrated and most people don't appreciate that. But the term ventilation, people talk about it as quality ventilation. Well, but it really is quality respiratory support. And I'll show you why I define it that way in just a second. And Peter, is this going okay so far? Are you there? I know Peter's still there. Maybe he's not.
Yeah,
so, of course. Yeah. Okay, good. So I'll make sure I'm not going too fast. I want to make sure I'm keeping my cadence okay for you all. So if you're going to still talk about quality ventilation or whatever you want to say, you need to ask the question, why do you need to ventilate? Okay, so in the cardiac arrest case or trauma, like a very severe hemorrhagic shock case, as I said, or hemorrhagic states, why do you need to ventilate? So the answer I typically get if I'm in an audience is to oxygenate the patient, right? But here's what I'm getting at, is that though they're intertwined, there's a difference between what we need to do for oxygenation and what we need to do for ventilation. And the reason why is that they are two physiological issues for me, okay? So oxygenation is saturating red cells. That's your goal that you're trying to do from a pulmonary point of view. I'm not necessarily talking about cellular respiration, but from a pulmonary point of view, you want to separate out oxygenation, which is saturating red cells, versus ventilation, which is for me clearing CO2. So that's one of the things that I thought that was great what Peter brought out when he was talking about overextended ventilation does not really equal hyperventilation. Hyperventilation for me is physiologically speaking, semantically speaking, but for me as a physiologist means hyperventilation means you have a low carbon dioxide level in your bloodstream. That's what it comes down to, or entitled CO2, whatever you want to say. Whereas hypoventilation is a whole different thing. It means that you're not clearing enough CO2. So what's a condition, for example, that you're breathing real fast, but you're not clearing CO2? Well, like a COPD, right? So you could be hypoventilating and you could be, but breathing fast or being breathed fast, and you may still have hypoventilation under those cases. So I don't interchange those words. I'm very careful when people say, I want to avoid hyperventilation. So to me, when someone says that, I'm thinking, oh, they want to avoid lowering carbon dioxide, but that's not what they're saying. They're talking about the effects, I hope, they're talking about the effects of positive pressure ventilation on circulation, and we'll get into that in some more detail. All right, so let's give you an example of what I mean by this. Just to give you an idea, this slide comes from like 1975, you'll see, and you'll see a lot of other things in my talk that they won't be wearing gloves. Back in the 70s and 80s when we didn't have infectious diseases around, I said ever sarcastically. But this is a model that I kind of drew up for students, back in Seattle in the 70s. And so here's your venous return coming in like here, past one area here. Here's one coming this way like this. And then here's an alveoli that's open, and here's an alveoli that's alveolus that's closed. All right. Representing a lot of other alveoli in that area. Okay, so what I'm showing here is that your red cells are not oxygenating as they go by this thing, and they never get oxygenated, whereas they go by this open area and they get lit up, and so you saturate the red cells. So you've oxygenated this particular blood vessel pretty well, whereas nothing's happened here. So the question is, how do I correct that? How am I going to improve, let's say, the oxygenation under this? And the reason why I say that is that when you get a shunt, that means something that looks like this, which could be pus, blood, it could be atelectasis, it could be whatever. If you have enough cells alveoli that look like this, then what's enough? You get into the realm of 15% of the lung, 20%, you're talking about really significant shunting and hypoxemia as a result, and therefore hypoxia at the tissues. But here, even if you got 80% of your lung zones open like this, you can still clear CO2. So it's really easy. You can have someone like with pneumonia and has a socked in area of the lung with pneumonia, and they will have a let's say an oxygen level that's hard to correct even with 100% oxygen, and yet at the same time they'll have a CO2 level, PaCO2 of I don't know, 12 or 15 or whatever it might be. So the point here is that how do you fix this? How do you clear up those if you have a lot of lung zones that look like this? What do you do? Well, obviously, if you in this situation put 100% oxygen in there, it's not going to fix it. If you breathe faster, it's not going to fix it. What you need to do is what we say is re-recruit those areas or re-inflate them if it's an atelectasis issue, which takes us to the realm generally of what we see with cardiac arrest, of course, because we're pressing on the chest. We are, for one thing, right, let alone the fact they're not taking breaths. So there's a tendency to deflate lung zones and therefore have a problem, not only in terms of oxygenation, but also getting blood through those areas of the lungs, as you'll see. So faster, here's the bottom line here of this oldie but goodie chart. Faster rate or supplemental oxygen will not help deflated lung zones. You need an adequate lung inflation for not only better oxygenation, as we'll talk about, also better transpulmonary blood flow during those chest compressions. All right. Peter, is that okay so far? Any questions about that as I get to that? That was the important part, right? So
I thought that was a great slide. No, that was a great
okay.
description.
So just want to make sure. I'm sorry because I can't see the audience, and so it's a little difficult. So all right. So here's the point then. That for oxygenation. Now, if you have areas that have VQ mismatch, partial shunt, in a sense, then 100% oxygen can work there. So my approach to oxygenation is adequate lung inflation and supplemental oxygen. There you go. And there'll be some studies coming out pretty soon from Australia showing that you're not going to hurt anybody. And in fact, you can harm people by not giving, say, 100% oxygen in those initial moments, et cetera, of cardiac arrest. All right. So we have a lot to go through, and this may end up being a part 2, but that's an important thing to understand. You have to have an adequate lung inflation, especially during CPR conditions. So what's a normal tidal, or what's an adequate tidal volume? Well, over the years, we found, of course, normal breathing generates negative intrathoracic pressure. Your diaphragms generate about, at rest anyways, at 80% of what you breathe. It pulls down almost like a syringe pulling down. It sucks air into the thorax, okay? And then as we move along, you've got the lungs are pulled open in a very specific architecture. As those diaphragms contract and they flatten out, they pull the lung down, very specific architecture. And it is primarily at the base. So there are what we call dependent lung zones down there to be opened up and closed. Now, you and I usually breathe about 5 to 7 mils per kilogram. So if I'm the classic 60 kilogram person, I'm breathing 300 to 350 is my tidal volume that I'm bringing in. But what most people don't know is that you're also regularly taking sighs or even frank yawns from time to time to re-recruit the gradually deflating dependent lung zones that we get even with normal tidal volume. Okay. And then, so that's the key thing. So most people, when they first started doing research on this and giving ventilation to people and so on, let's say, or to breathe for them in the operating rooms, they found out actually that if you gave this breathing level of, say, 300 to 500 in that area, that they were starting to desaturate. Oxygenation levels were desaturating. So they later figured out that they were having to add size. So in the old times, they had on the ventilators, they would have size put in. So they would give you a big breath of about 10, 15, 20 mils per kilogram tidal volume, just intermittently to keep it inflated. They later found out that you could actually get away in the average lung is up to much as 15, 16, even up to 18 mils per kilogram without any barotrauma whatsoever. And it was a problem. So generally they backed off and just said, let's give them about 10 to 15 mils per kilogram. And that's what they typically did. Going forward later, when people had ARDS studies, and that's a whole nother topic with diffuse lung disease in different areas, you could overstretch, especially because you're putting lots of PEEP on board. So that was not, you'd want to back off, but you have lung inflation due to the PEEP. So that's a whole nother story, but that sort of got misinterpreted. But we still probably need to be giving more than this 5 to 7 mils per kilogram for a lot of reasons, especially during CPR. So anyways, the other thing about positive pressure ventilation is that it generates intrathoracic pressure, pushes the lungs open, right? And that diminishes venous return and resulting in cardiac preload, right? And most of us have finally come to understand that. A lot of this was based on my work in the 70s, and I kind of got that, and we made sure that we were not giving too much positive pressure ventilation. I'm going to show you the strategy that we used in just a second. So because this diminishes venous return and resulting cardiac preload, we had to be careful about how much positive pressure we were putting in there. I'm going to tell you, I saw paramedic protocols back there that were talking about that you were supposed to give like 18 to 25 breaths per minute because they said you had to combat lactic acidosis, whatever, by lowering carbon dioxide and all sorts of things like that back in the day. And I think people have finally come around and appreciated this, but it was not really well appreciated even 10, 15 years ago. All right, so the other thing you need to know, when you're giving a positive pressure breath, you're maldistributing the lung. So instead of going into trying to push the diaphragms down, a lot of the air that will go in will have a maldistributed manner into areas of less resistance, not the diaphragm as usual. So the normal tidal volume does not necessarily open up some of those dependent lung zones that we're talking about, right? And it also increases intracranial pressure because you got pressure in there that backs up on the vein side. And I think with the heads-up CPR stuff that we've been talking about in the past, you know how important it is to lower intracranial pressure so you can get blood flow across the brain as well. So this worsens the chest compression effect and compromises cerebral blood flow as well. So every time you give a breath, it's got a little bit more harm. So you need to develop a ventilatory strategy to diminish mean intrathoracic pressure by lessening the need for positive pressure. And so what I'm saying, I'm going to give you a strategy for giving a more efficient breathing approach. So let's give you an example. So Peter brought up this thing about the small bag. I saw one the other day. I'm out here on the streets with the various people, and we saw, I saw small bags being used. I'm going, oh, that's not going to inflate that guy's lungs. So I'm just like scratching my head. And I think the intent was to use these things to avoid, I think they were saying barotrauma, and that's another whole other subject that it's not this poorly understood. And secondly, is that it basically was done to maybe keep people from giving too many breaths or too much intrathoracic breath. The problem is that that's that compromise of not getting enough blood flow across the lung, let alone oxygenation. So let me give you an example. And again, I think because of time, I may come back to this whole subject again, particularly in the area of hemorrhagic states, because you're going to see in the future going forward as we give blood that it's better to give blood first before you intubate, or whatever, and give positive pressure. Because once you start putting a tube in, then people have a new tool to harm people with too much positive pressure ventilation. Yet you need to make sure that they're getting adequate lung inflation as well to get the blood across, whatever it is. So there's be evolving evidence that will support everything I'm saying here today. All right, so let's talk about larger tidal volume versus a smaller tidal volume. That's because Peter brought that up, and so I might as well address that. All right, so a minute ventilation of 5 liters is what we're doing here at Rest. All of us here are probably breathing about this much, maybe me a little bit more because I'm talking. But let's just say there's several ways to approach giving 5 liters per minute. That could be, as an example, one example is 500 times 10, or we give 1,000 times 5, right? Okay, so let's see how that means. Now, the key thing is when I'm clearing CO2, right, what I'm trying to do to remove the CO2, what I'm doing is basically making sure I have enough alveolar ventilation, right? There's a difference between minute ventilation and alveolar ventilation. So consider tidal volume minus the dead space in terms of actual alveolar ventilation, which clears the CO2, and does whatever else we need to do for lung inflation. So if you have 500 minus 150, you get 350 times 10 means that you have a minute ventilation of 5,000, but you only have an alveolar ventilation of 3,500. All right, let's move on then. Say, let's take that 1,000 minus 150 gives you what? 850, and you multiply that times 5. It's still a minute ventilation of 5 liters per minute, right? But you're getting alveolar ventilation that's much higher. In fact, if I just backed off to 4 breaths, right, less breaths I have to give, it's almost the same as given that 10 times the 100, the 10 times the 500. So bottom line is a larger breath is more efficient ventilation wise. I get away with fewer times I have to inflate the lungs. then you might say, oh yeah, but you're inflating the lungs more. Okay, so you're putting more pressure down there. Well, one of the interesting things you find is that as you kind of stretch the thorax out a little bit more with that larger breath, what kind of happens is that you eject it faster too, at least in normal lungs. And we'll talk a little bit more about how you handle other situations. But the general patient you're facing will do much better with a larger breath, and it's more efficient ventilation wise. And of course, it's going to be better for your adequate lung inflation that you need to achieve. So that oxygenates better, pushes more lung zones open, correct? Especially since you have maldistribution of air as you give a positive pressure breath. It ventilates better. It means that it removes CO2 more efficiently. You could get away with 4 breaths per minute instead of 5 with the same minute ventilation. And the expanded chest ejects the air more forcefully. So what happens, this means over, let's say, a mean intrathoracic pressure, let's say over a period of a minute or so, you're giving fewer breaths over a minute and it's ejected faster. So you kind of minimize the effect on intrathoracic pressure. So you're getting one, better blood flow, okay, through the lungs, fewer intracranial pressure increases during compressions, and it helps you. So this is better CPR, let alone the fact that it's better, respiratory support. So when I say respiratory support, let's go back to that. I mean that respiratory support is that you have to make sure there's oxygenation and of that bloodstream saturating the red cells, and you have to make sure you're ventilating, removing CO2 well. All right. And it turns out that you won't have to worry about removing CO2 much because you're not producing much during these kinds of states. But more preload allows more transporting blood flow, so that's where you're going. All right. So what's an adequate tidal volume to choose? And so because in the interest of time, because you're going to have to wrap up, this will be a two-parter, I think, is that the 8 to 10 mils per kilogram we use when we do this in the laboratory is with the caveat that you're like intubated, okay? That's, or it could be an eye gel, it could be, whatever you're using, endotracheal like we always did. No PEEP, okay? And no diffuse lung injury. And what I mean that the ARDSNet trials show that you have diffuse heterogeneous lung disease. Some areas are open, some are closed. If you have ARDS, that's a situation in which if you apply a larger tidal volume and now you're applying PEEP, well, that's a whole different story. Now you're stretching the lung, stretch on top of stretch, and you are going to get barotrauma. So in those studies we showed you need to go, if you have a lot of PEEP on board, you need to be, then ventilating with, smaller tidal volume. So that's a whole different thing, and that's been kind of applied, and people call it protective, lung protective thing. Well, but it's a whole different can of worms with what we're generally dealing with. So one of the things that I learned from Peter Saffer early on and everybody else, they said, well, don't worry about measuring it. Now we have tools to measure this, by the way, but you can do pronounced chest wall raise. Now that's not perfect. There's a lot of, with the maldistribution issues I was talking about before. But the big issue I do want to get across here is that, let's get the chest wall raised, or you can probably even calculate from that bag. That squeeze there is about 1,200 cc's, by the way. And I've always had a pretty good handle on, how much you're giving as you do that. But I think the big issue that we're not paying enough attention to is that you've got to give a steady squeeze and a very quick release. So that air doesn't, distribute out like past your bag valve device, mask, or past your eye gel or anything else. Make sure your air is getting into the right lung zones. I give a steady squeeze, like over 1 or 2 seconds, and a quick release. And let me tell you why that is. In some studies like Tom Ofterheide did years ago, he found that people were not paying attention. In fact, he'd squeeze and then hold it in. So then you're maintaining the positive pressure in the chest. So there are so many aspects to how to breathe people, and I hope to come back a little bit more and talk about. So you make sure that they're giving that steady squeeze, and then they're releasing quickly, and do not prolong the positive pressure time over that period of time. So ventilation is clearing CO2, as we talked about before, and so we've chose a tidal volume, right, the times the respiratory rate. So now what we have to do is pick a respiratory rate. And as everybody knows, with cardiac arrest and little oxygen delivery and consumption, that there's little CO2 production and venous return. So there's little need to ventilate to remove that CO2 in most cases. And then I want to come back later to y'all and talk later about auto PEEP and hypovolemia, how they contribute to this, especially in cases in the hypovolemia, very serious. You'll just kill people with positive pressure breaths, even at a fairly low rate. And when I come back, what I will do is mention to you that generally what I do is I give a good lung inflation, and only give the breath maybe once every 10 seconds, because you don't need to ventilate, but you need to oxygenate under those conditions, and you need to make sure blood is getting through the lungs. And with that, I think, Peter, I think what I want to do is, cut it off at that point and maybe come back and reiterate this a little bit. But I think this is a good primer to get them into the realm, and I'll come back and show the effects they have in just moderate hemorrhage, studies that we did and all that in the traumatic edge. I think that'd be good. We can call it the area, and I'll do a refresher on a lot of this stuff, but we'll come back and even talk about how this has worked for us, amongst children, et cetera, in studies like Paul did so nicely up in Polk County, so on. So Florida's taking the lead again here, Peter. So thank you so much. I'm going to drop it off to you because we got to get on to the other one. But I wanted to make sure I went over the physiology a little bit, and it's more complex than this, but I try to make it as user friendly as possible under these circumstances. So okay. So
Paul,
yeah.
that was amazing. If possible, I'm going to share my screen. I'm going to have you comment just in the 2 minutes we have left.
Okay.
On this study, and I'm going to show I'll show about a minute of it, and then because this goes exactly to what you're saying. Paper just released from the folks in Seattle, association of small adult ventilation bags with return of spontaneous circulation and out of hospital adult cardiac arrest. And again, they ended up they started off. This was from 2015 to 2021 in Seattle. They whittled it down. They had 3,200 patients. And it's including about 2,000. And some interesting things. First of all, in that, look at their bystander CPR rate in Seattle. This is why I think they're always year after year that they do so well. Yeah, they have a very high in Florida. It's about 29%. A very very small percentage of these patients receive an IDEL, which I think is different than the rest of the country. I found that pretty fascinating. But let's get down to the answer here.
Just a quick reason for that is that they have a small cadre of paramedics, and then most of their EMS is run by EMS, and so these guys are pretty highly skilled. And we trained them the right way, by the way, in some of the things we were just talking about. So, okay, go ahead.
Right. So you could see here that using a large bag, they had better outcomes, including a CPC of 7 versus 5. And that's actually with a p-value of significance. Yeah. Here's another very interesting graphic, the odds ratio plot, and you can see that the large bag was favored with asystole, PEA, unwitnessed arrest. Look at the male versus female difference, which would make sense, right? And then overall, you could see that it favored the large bag. So everything you're talking about, really held true. And then going over to the ventilation aspect of it, you could see that the large bag ended up having a lower mean end tidal CO2. So I would love for you to comment on that particular aspect in relation to what you just said in the next 30 seconds.
So, I think that's appreciated. They may not even appreciate why. Maybe they're thinking in terms of, everybody keeps thinking in terms of respiratory, but like in the laboratory, we see pulmonary vascular resistance going up if we're not giving 10 mils per kilogram tidal volume. So, with especially, in the work with Keith and what we're doing there, we're looking at everything really closely, and and it's really cool because it's totally validating what we've been doing clinically over the last 2 or 3 decades in our shops anyway. So I mean, the only thing to say is that I don't know what else to say. It goes along with what I was telling you, that you first, okay, so just think about it. Oxygenation is not how fast you breathe, people. It is giving 100% oxygen, yes, and that's okay, by the way. And it also is making sure there's an adequate lung inflation, which in our case is a good, moving the chest wall up if you have to, but it's around 10 mils per kilogram probably is adequate. And we're seeing that in the laboratory. And then just giving it at a much lower rate, and you can get away with a lot because and there's not a lot of need to ventilate under those circumstances, by the way.